we often operate with preconceived notions of what gender means and how gender affects health system responses to people's vulnerabilities and risks. And one of the things that we have discussed a lot today, and reflects many years of thought about this, is that, first of all, just the message that by gender we are not talking just about women. We're very much talking about everybody in the population, recognising that as a social construction, gender is something that everybody has. It's not unique to one half of the population. But quite often when we design health system responses to gender, we tend to focus just on one half of the population, for reasons that are entirely understandable in terms of women's inherent vulnerabilities, women's inherent inequalities as far as gender norms and gender constructs in multiple areas of their lives are concerned. But in terms of the health system, what we need to recognise is that a gendered health system response is not the same as a health system response that focuses just on women and girls. And there's plenty of evidence to show that women and girls get treated very differently to men and boys when they get into the health system. But there's also plenty of evidence to show that men and boys are much less likely to get into publicly funded health systems in the first place. So if we're taking a gendered lens to health systems, we need to truly take a lens that looks at the risks for everybody of not addressing gender.
Gender shapes our vulnerability, our risk factors, and also the autonomy, the decision-making power, and the opportunities we have to seek care, what sort of care we seek, what sort of services we seek, where we do it, and when we do it. And I think a lot of the evidence we have is around gender risk factors and healthcare seeking, but health systems goes way beyond that too. Gender does shape all the different angles and different elements, and we've spoken this morning about thinking through the World Health Organization building blocks, and for example looking at financing and how financing structures again shape the costs and the opportunity costs of seeking care for different groups. And we've talked about human resources for health and how, again, there are strong gendered patterns there. So from the Guinea-Bissau example, there's very few women healthcare workers, where in Zimbabwe we know that most nurses are women. And we need to look at remuneration and opportunities for promotion across the whole health system, including the too often neglected and negated community health workers, who are critical bridges between the health sector and communities. So gender is important for health systems at multiple levels, and we need to ensure we have a holistic analysis that looks at the health sector as a whole and also supports and builds partnerships beyond the health sector. And I think those of us working in the health sector have the opportunity and the responsibility to think about our actions and what we can do to promote more gender responsive approaches. So health systems reflect contexts, but they also have the opportunity to change context for the better.